Okay, so welcome everyone. My name is Dawn Richards, and I'd like to welcome all of you as the Vice President of the Canadian Arthritis Patient Alliance, or CAPA, as you'll hear me call it today, to a webinar about COVID-19 vaccines and living with inflammatory arthritis. So we may touch on other vaccines too, like the flu vaccine. So to get us started off, I would just like to welcome all of you and to recognize that I live, work, play, and learn in the city of Toronto. And that means I am a white settler on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And I'm grateful for them as stewards of this land many thousands of years before I arrived. And I feel it's my duty as someone who lives here to learn from the many First Nations people, Inuit and Métis people, and their ways of living on the land and respecting the land. So I'm going to ask my colleague Lori Poole to put the website address for CAPA into the chat, and we're going to put a few of those in as we go through the webinar. I had asked people to please just mute yourself and to also turn off your camera as we are recording the session. We'd ask you to post any questions that you have in the chat as we go through the webinar, and we're going to try and get to as many of those questions as we can. And we've also tried to collect lots of questions from people in advance of today's conversation. So we hope that we can answer as many of your questions as possible. We would ask you that when you ask questions to please keep them general, questions that others living with inflammatory arthritis might also ask. We'd ask you to please not make them specific to your medical situation, as we can't give out medical advice on the webinar. So today I'm privileged to have three guests with me who will be having a conversation with me about COVID-19 and other vaccines and living with inflammatory arthritis. So we've got Nadine Lalonde, and I'm going to ask everyone to introduce themselves instead of me doing that for them. We've got Dr. Dawn Bowdish, and it's weird for Dawn and I to both have Dawns on the same webinar. And Dawn's an immunologist. She'll tell you a bit more about herself. And then we've got Dr. Inés Colmegna, who is a rheumatologist. So why don't I start with you, Nadine, then we'll go to Dawn for an introduction, and then we'll go to Inés. So take it away, Nadine.
Hi, everyone. My name is Nadine Lalonde, and I live with lupus and a few other conditions that are lupus related. I've been on disability since 2018, and during the pandemic, that's when I heard about CAPA. I was referred to CAPA by a friend of mine when I was looking into why the government was at first not recommending the vaccination for people with immune disorders. And once I found out about CAPA, it made me sort of look towards other ways of getting involved as a patient partner. Currently, I do volunteer, I guess is a better way of putting it, but it is work whenever we do it, as a patient partner with a few Canadian organizations, and I'm very happy to be able to do that and provide a patient's perspective.
Thanks, Nadine, for being here. Dawn?
Hi, you can call me Dawn B when you need to distinguish between Dawn or you can call me Immunology Dawn if you like. I am an immunologist at McMaster University. I'm the Canada Research Chair in Aging and Immunity, and my research interests pre-pandemic were the aging immune system and how that impacts respiratory infections and vaccinations. So when COVID came along, I was positioned to help assist with a number of studies. So I run one of Canada's largest, or co-lead, one of Canada's largest studies on COVID vaccinations and infections in older adults, and also work on a study with Dr. Colmegna on vaccinations in immunosuppressed people. My lab's specifically been focusing on rheumatoid arthritis and some of the drug vaccine interactions. I'm also an enormous geek who will talk forever about the immune system. So I will rely on our moderators to tell me when enough is enough, because I have more fun facts for this audience. You probably know what to do with.
Amazing. Welcome all geeks. I'm also a giant geek. So we have more than just a name in common, Dawn. And Inés, to round things up.
Good morning. Thank you for the invitation. It's really great to be here and be with all of you. My name is Inés Colmegna. I am a rheumatologist. I am on call at the Montreal General Hospital. I work here at McGill, and I also do research. And the objective of my research is to try to decrease comorbidities, specifically things that we can prevent, such as infections in people that live with autoimmune conditions, specifically rheumatoid arthritis. So again, thank you so much.
Awesome. Thanks a lot, everyone. And I guess I didn't let people know too that I also live with rheumatoid arthritis. And so along with Nadine, I might bring in some of my perspectives throughout the conversation. Okay, so we're going to start off by asking Dawn B to share with us a bit about how our immune system works. Or, you know, we've already kind of got wonky immune systems because we're all living with some kind of autoimmune disease. So how is our immune system supposed to work when we receive a vaccine? Can you talk about how long this response should last, and what is the response in the first place?
Mm-hmm. Well, this obviously is a complicated topic, but I'll focus on the COVID vaccines, and you can extrapolate to other vaccine types. So one of the reasons we get the vaccines in our arm is because that's the site that drains to your lymph nodes under your armpit. And so what happens when you get that injection, in the context of the vaccines most of us had, were mRNA that encode the spike protein. And the spike protein is what the virus uses to stick to us. So by generating antibody responses to that spike protein, we can stick antibodies onto the spike and stop it from getting into us. We get the injection, that mRNA starts turning into the protein. The immune cells bring everything down to the lymph node. There's a bit of an immune cell party where you have your B cells and your T cells and all working together to make two sort of types of immune responses. The one type are the antibody responses, which we hear a lot about, and you'll often hear this in the context of like waning antibodies. Most of us measure antibodies because they're easy to measure. But there's also a second component, which is what we call the cellular immune response. And what we're learning about COVID is that vaccination has two major ways of protecting us. It's one of the things it does is it has the capacity to make these antibodies that stick to the virus and keep them out of us. There's also antibodies that have other functions. They can help train the immune system to recognize the virus. But there's also the cellular response. And the cellular response can involve making what we call memory cells. So they are expanded during the context of this vaccination. They go down a little bit, but they're really primed to respond really quickly to the next time. And one of the reasons that in COVID, we see that protection from getting infected is pretty short, but protected from death and dying and ventilation and all those terrible things we heard about in the beginning of the pandemic is much longer, is because those cells that are longer lived tend to help us out with that. One of the things about adult vaccinations that I think is important to understand to sort of set our expectations, influenza, COVID, other things that we might be vaccinating for as adults tend to be what we call disease modifying. So they tend to make the disease a little bit better, but they aren't 100% protective from infection. And just to give you the example of influenza as a vaccine we're all super familiar with, on a good year, and when everything's all matched and you get your flu shot, you can expect about 60% protection from symptomatic infection, but much higher for hospitalization and death. That goes down about 10% every month. So if you get vaccinated in October, you're at 60%, then 50% November, 40% December. I'm going to get the math wrong if we keep going, but it lasts about 6 months.
Okay.
And coincidentally, cold and flu season, influenza season, is about 6 months. So you have a lasting response. What we're learning in the context of COVID is that period of symptomatic protection is shorter, probably not more than about 3 months. And it does wane as well, but that protection against death and serious disease is really much, much higher. The challenge with COVID, as you are all very well familiar with, it's not a once-a-year season, is it?
Right.
It's come really reliably, March, August, sort of November, December. And one of the challenges has been keeping those vaccines up to date to give us that maximal protection during these waves, which has been really challenging. Now, in the context of inflammatory diseases, one of the things that people sort of misinterpret is they say, I'm at more risk. I know I'm at more risk of severe disease. So maybe the vaccines don't work as well for me. In general, it's not the disease that's the problem, it's the medications. Because many of the medications that you'll be so familiar with work by dampening that immune response. And so in general, what we find is that people on immunosuppressive medications either need more vaccines to get to that 60% protection. And because they don't have such a strong immune response, waning is faster. So whereas somebody who's young, a nice teenager who have those beautiful, robust immune systems might be able to expect, 6 months of protection in the Omicron era. As we get older, that gets shorter. And as we add immunosuppressive medications, that gets even shorter. So that's vaccination in a nutshell.
Okay, and Inés, maybe I can ask you about some of the medications that we take as people with inflammatory arthritis. What are the ones that Dawn just kind of mentioned that have the biggest impact on our responses then to the COVID-19 vaccines and others? And do you have any potential general advice on if and how people should hold their medications before they get vaccinated, et cetera? What can you share with us about that?
Sure. So there are different types of medications that are used for different conditions in rheumatology. If we look at the different studies, the group of medications that are associated with the lower response to vaccines are those medications that decrease the function of B cells. So I'm sure some of you are aware of the medication which is called rituximab, or sarilumab or belimumab. Those are medications that affect the function of B cells, and that is associated with a reduction in the production of antibodies. But as Dawn said, it's not the benefit of the vaccine is not based on antibody responses. There are cellular responses, and there are some studies specifically done in people that have multiple sclerosis that require, or in this particular study were treated with rituximab, that show that the cellular responses seem to be quite preserved despite of the lack of antibody production. The American College of Rheumatology has tried to put together all the data that we have so far to provide guidance related to the use and timing of immunomodulatory therapies in relationship with COVID-19. And there is a small table that that you have a reference in a handout that I sent to Dawn yesterday, which specifically looks at each medications and the timing considerations and the level of consensus, because again, there is more and more data, but the important thing here is that this is a decision that needs to be made with the physician that treats you, because the same medication in a patient that is very well controlled and with in remission can be more safely stopped than other medications in a patient that requires them because the disease activity is not well controlled. So, for example, if we think about abatacept, there are some moderate level of suggestions to stop or withhold 1 or 2 weeks after each COVID vaccine dose. If we think about TNF inhibitors or anti-IL-6 or even anti-IL-1, there was not clear consensus in the task force that worked in trying to develop these guidelines in order to what is the best way to proceed. If we think about hydroxychloroquine, for example, there's no reason why hydroxychloroquine should be stopped. And if we think about rituximab, if possible, we usually, there is evidence to suggest to get the vaccine right prior, couple of weeks prior to the next dose of rituximab, which is when the immune system seems to have already started to recover from the previous dose of rituximab. So I think the key message here is that there's not one rule that applies to all the drugs, and there's not one rule, even with the same drug, that applies to all patients. This is something that I would encourage all of us to discuss with our physicians and to see what is the best approach prior to vaccination for each individual person.
Okay, thanks, Inés. So basically, these vaccines aren't that different from how we work with our rheumatologists and maybe our pharmacists also to figure out, the current medications that we're on, right? It's kind of the same approach of it's very much tailored to our own situation, and it should be a discussion that we have with our healthcare provider about what might be best for us. And I know that, when the vaccines first came out, and to Nadine's point, the National Advisory Committee for Immunization in Canada, which we sometimes called NACI, had originally recommended that people like Nadine and I not have access to the vaccines because folks like us weren't in the clinical trials for the vaccines. And so I guess I just wanted to let people know that CAPA worked quite closely with Inés and other colleagues at the Canadian Rheumatology Association to find ways to look at evidence or extrapolate evidence so that we could make a case for the fact that just because we weren't in the trials at that point didn't mean that we shouldn't have access to vaccines. The flu vaccine is one that's really important for us as well. And we're often, not in a number of different studies because of our immune systems and how they respond. So just wanted to point that out. And Lori has put in the chat the document to Inés that you had provided from the CRA, or the Canadian Rheumatology Association, about COVID-19 vaccines. So think about those types of organizations for evidence-based information on vaccines versus some of the other places where you might find information about vaccines. These are evidence-based and credible organizations. So Nadine, I would like to ask you about your experiences with the COVID-19 vaccines to the degree that you're willing to share, and what kinds of vaccines have you taken? How did you react to them, with the caveat that that's very personal, like that's your situation, right? And back to Inés's point, many of us will react differently to different things based on our own situations, but we'd like to invite you to share your experiences, Nadine.
Sure. So I ended up having all three of the main vaccination types that were available to Canadians. So I started off with the AstraZeneca because it was opened to people 50 plus before the mRNAs were available to people with immune disorders. So I started off with that one, and then I had the other two, the Pfizer and the, what's the other one called again?
Moderna?
Yes, thank you, Moderna. And I would say that it's really hard to define what was vaccination, what was possibly flare and what was holding some meds, because at the time I believe my second vaccination, there wasn't a whole lot of information about whether or not to withhold meds. And I take prednisone, and that is going to be a question that I'm going to, throw back to Dawn and Inés. Where does prednisone fit in all of this? Because a lot of people with immune disorders are on various doses of prednisone and may have some worries about that. So in my case, it was really hard for me to tell which factor was coming in, which factors were coming into play. I did have some, a little bit of a flare. You know, I had the usual things that everybody, you know, or most people or a lot of people had, like sore arm, fatigue, maybe a little bit of extra sort of muscle pain, that sort of thing. But I had some more lupusy type symptoms, which again could have been flare from the vaccine, could have been from at least one of the times withholding my prednisone, not being sure, you know, what to really do, and honestly not having the clearest guidance, because that was when everything was changing on the daily basis. So it was kind of hard to know, this week what do we do, next week what do we do. But all in all, it wasn't a horrible experience any of the times that I've received the vaccine. But you know, some minor issues, which I believe was probably experienced by a lot of people with immune system disorders.
Thanks, Nadine. I know, like you, I am a shopper of different types of vaccines. Basically, I was like, hand me whatever you've got. But at one point as well, I also opted for the Novavax vaccine because of some of the studies that I had read about. And so that was the only vaccine that I didn't feel like I had any kind of reaction to. Like I didn't have the sore arm, none of the fatigue or kind of the latest vaccine like really knocked me flat out for a day or so. It was a different experience. So it's always kind of interesting with each one of these, what it's been like basically. So Inés, I wanted to ask you, is there data at this point that shows whether or not the COVID vaccines actually cause an increase in flares or different effects?
So that was something that we definitely wanted to generate data from the very early stages of the pandemic. And there are several studies now that have shown that COVID vaccines are not associated with an increased risk of severe flares in people with rheumatic conditions. What it is important to say, because I'm sure all of us say, well, but you know, when I received my vaccine, I had a lot of pain. I had to take more anti-inflammatories, or I had to contact my doctor because they were. So there are individual cases in which, yes, there are flares, but those flares are not severe enough or persistent enough to make the patient go to the emergency room or to be admitted or to require changes in treatment. So again, exceptions always happens, but the studies consistently show that these vaccines are safe in terms of not an increase in the frequency of severe flares in people with rheumatic conditions. It is also important to acknowledge that the side effects that are seen in the general population are also seen in people with rheumatic conditions. So we need to remember that adverse events are defined based on how frequently they occur, and minor adverse events that are very common are those that occur in more than 10% of the population, such as pain at the injection sites or a little bit of redness or fever or fatigue. The frequency of those side effects are the same if you have a rheumatic condition or if you don't have a rheumatic condition. So I think the bottom line here is vaccines today, we can say that they are safe with regards to their use in patients with rheumatic conditions. And the advice that we need to provide in terms of what is expected after I receive the vaccine, which I'm sure most of my patients know that better than myself at this point, is exactly the same side effects that you would expect if you would not have the diagnosis of a rheumatic disease.
Okay, great. Thanks for that. So basically, we can expect to have the same kind of side effects as our family members, recognizing that there's always unique cases, right? Where, you know, people might experience a flare or might experience something different, but the data is pointing towards the fact that that wouldn't be a typical case per se. Okay, great. So I see a question in the chat. And maybe, Dawn, I can direct this to you. Any comments about nanoparticles from the mRNA vaccines? What can you tell us about this? Go geek out, Dawn.
Let's get geeky. So vaccines only work if they trigger a little bit of inflammation, because if you need to send your immune system what we call a danger signal, otherwise your immune system interprets it as food or dust or all the stuff you breathe. So think of all the stuff you put in your body in a day, the stuff, creams you put on your face, the stuff you eat, the dust you breathe. All that stuff you don't generate an immune response to it because there's no sense of danger. Vaccines, you have to have a little bit of danger. And so one of the evolutionarily ancient ways of signaling danger is two things: swelling. So when you put the vaccine in your arm, that swelling you get is sort of all the water sort of coming in and all those immune cells coming in, and a little bit of damage to the cells. So each cell in your body is mostly water in the middle. And to keep the water from leaking all over the place, you have a little bit of lipids or oils on the outside, a little shell of oils. And the lipid nanoparticles sounds like a piece of metal or something. Nano just means size, but what it actually is, it's the same thing. It's a liquid in the middle, water in the middle with the mRNA, and a little bit of oils on the outside to keep that mRNA in there. To get the mRNA to make the spike protein, you have to get that mRNA into the cell to start making the spike protein. So if any of you cook and you've ever made salad dressing, you know, if you put your vinegar and your oil, they separate, right? And you have to shake, 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 shake to get them all mixed up together. What those lipid nanoparticles do, because they're oils and your cell is oils, they can basically fuse and get the mRNA in there. And so although lipid nanoparticles sounds like something, I don't know, concrete, effectively it's salad dressing. And it's just this oil that helps bring the mRNA into your cell and then start that process. So it's made out of the same lipids that make up your cells, the cholesterol. So it sounds like a thing, but effectively it's salad dressing, or it's your own oil sort of repackaged. And just to give you some context, the other vaccines that we've had traditionally also have to break apart cells. So the two things that we put in them traditionally are alum, because it's a big spiky crystally thing. And so it's like, imagine your cells are balloons. You put the big spiky thing in there and they all pop, and that's how you get that little bit of damage signal. Or we basically put detergents. Just like, you know, if you want to clean up your oily dishes afterwards, you have to put soap on to break up the oils. So some of our vaccines have effectively detergents in there. So there's basically three ways to give a little bit of that danger signal and get the vaccine there: soap, oils, or spiky things. And the mRNA use the lipid nanoparticles, which are the oils, and the other ones use spiky things or detergents. It's just that simple. So there's no,
Okay.
you know, I know there's been a lot of drama about these things and they sound like a thing, but you could drink them if you wanted to. It's
So
really
they're safe, basically.
Yeah, it's very, very safe. Very, very safe.
And essentially it's just a way to deliver something from, you know, one vehicle to another, is what you're saying.
Exactly.
Okay.
And they're, like I said, they're made out of the same oils that your or lipids that your body's already made of. So it's not something that's seen as particularly foreign. It's just a way of mixing these oils and waters together.
Okay. Yeah, because nano sounds like space age or something, right? And so almost kind of scary, but you've got this
very, 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 very
tiny.
small.
Yeah. Yeah, you've got a great way of explaining things, Dawn. Lots of stuff in the kitchen there. I feel like you like to be in the kitchen too.
I do, actually.
Okay. So moving on, another question we have is the safety of getting both the flu vaccine and your COVID-19 vaccine at the same time. And I know, Nadine, you recently had that. Can you tell us if, you know, what was it like? Just like getting any other vaccine, and then we'll move over to Dawn and Inés for what their take is as well.
Yes, so it was two separate vaccines. My mind at first, I thought it was going to be some kind of like combo vaccine, but it was, you know, one in one arm, one in the other arm. And I'd have to say, and that was just probably about 10 days ago or so that I had it. And I did find that I had a bit more swelling from the COVID one than I did from the flu one. But I didn't have any major downtime. Like I might have had a day of just kind of feeling bleh and, taking a rest and not doing too much on that day, but it really didn't hold me back. I didn't hold any meds or do any kind of, variation in my meds at all this time. And yeah, it was fine. I didn't have anything that I would want to report as being negative.
Okay. And what do the scientific and medical experts have to say? And I guess, Nadine, you've also triggered a question in my mind is, is there a movement to do like a combination vaccine as well? I'll put that out there too. Dawn or Inés, would you like to take that?
There certainly is a move to do that. I mean, one of the beauties of the mRNA vaccines is that you can mix and match. So there's been a couple trials, early trials on RSV, COVID, influenza altogether, influenza, COVID altogether. So there's a lot of movement towards co-administration, and Canada has never been able to get its adult vaccines up to the levels we want to have them. Our target has always been 80% of the population vaccinated for influenza. We can get 70 some odd percent of older adults and about 30% of other priority groups. So we've never got anywhere near that. And the hypothesis is if we made it easier, then everyone could get them together. In general, co-administration of vaccines is accepted. You can see the National Advisory Council on Immunization. If you're a big geek like me and you like to read the recommendations, they'll often have a section about you can get, shingles and your pneumococcal vaccine at the same time. You can get this vaccine and that vaccine to help with that administration. I was just recently referred to a publication about co-administration, and there was some suggestion that, were the responses absolutely equivalent? Maybe there were some subtle differences. So I think, it's worth studying to see with the COVID vaccines as being new vaccines, if they influence any of the other vaccines. But in general, it's very rarely are you recommended not to get them at the same time. But I'll refer to Inés as the expert, the medical expert.
So I agree 100% with what you said, Dawn. The Canadian recommendation suggests to get both vaccines at the same time, and the rationale for that, the reason for that is that decreases the likelihood that the patient feels that it's too much to go again to get the second vaccine, and ultimately resigns on getting one. So when we have the opportunity to offer a vaccine to somebody, we really need to take it. With regards to other specifications that the recommendations make, number one is both vaccines cannot be mixed in the same syringe. So these are two individual injections. They suggest to get one in one arm and the other one in the other arm. However, they say that if you want to get both vaccines in the same arm, there should be a separation between both injections of 2.5 centimeters. And then the question is it possible that in a few years we're going to get both vaccines mixed together and just get one shot? The answer is absolutely yes. The companies are trying to generate that combo. And I am convinced that probably is going to be what happens in the near future with regards to a combination of the COVID and the influenza vaccine.
Okay. Great. We've had some other questions too, and Dawn B, we didn't talk about this earlier in our prep, but can you talk to us about, if you can, about how Paxlovid works? And that's something that a lot of people are being recommended to get access to. So maybe you can share with us how it works. And Inés, if you can talk to us about, what the CRA recommendations are related to that, or what you've seen. And then I'm going to come to you, Nadine, if you're comfortable to share. And I apologize, I'm sneaking this one in because we didn't talk about this, but I think it's good for people to know. So Dawn, I'm going to start with you about how does this work when people have COVID?
So Paxlovid is what we call an antiviral drug, meaning it messes with the virus' ability to make more virus. And one of the reasons it's a great drug and is a bit of a godsend is because we know more virus is more problems. So if you're not able to control the amount of virus because you're older, you're immunosuppressed, you're unlucky, you're, one of these people who are quite susceptible to the virus, more virus means more damage to the organs, and it can mean that people end up in the hospital. So Paxlovid is a godsend because it helps to reduce the viral load really significantly. And that means that there are lower chances of both getting so sick you end up in the hospital, but also there's some data suggesting that because it reduces the viral load and the amount of damage, that there's less issues with long COVID and other health issues that happen after the infection. So I think anyone who's eligible for Paxlovid should make sure they have a plan to get it, because remember, the day you get sick, you're not going to be feeling very well. So you want to have a plan in place and access that drug if you can, because it does reduce risk of both the short-term discomfort and the long-term health issues associated with COVID.
Great, thanks, Dawn. And Inés, what can you add to that?
So essentially, if we think about who is eligible for Paxlovid in Canada, it's any patient who are at higher risk of developing COVID and have severe outcomes. Patients that have, there needs to be three criteria. The first one is risk of severe outcomes. The second one is you have to test positive for COVID. And the third one is that you have to be within 5 days of symptom onset. And the last one, of course, is not to have contraindications to get Paxlovid based on the opinion of the pharmacist or the clinician. And that is really, there is a list of things that you're going to be asked at the time that you request this. So this goes back to a question that was asked before, which was many of us take prednisone. Anybody that takes prednisone is at a higher risk. The answer for that is no. The Canadian the National Advisory Board for Vaccines suggests that people that are taking prednisone at a dose of 20 milligrams for at least 14 days are considered immunosuppressed. That doesn't mean that taking 5 milligrams of prednisone does not increase the risk of certain infections, but for the purpose specifically of vaccines, the definition is the one that I just mentioned, 20 milligrams for 2 weeks. And the point here is that definitely if we have a patient on high doses of prednisone, that patient is at a higher risk of having more severe outcomes. And if that patient tests positive for COVID, that patient will be a candidate for Paxlovid. And we use Paxlovid in many patients that unfortunately, while they are hospitalized, they acquire COVID in the hospital.
Okay. Nadine, are you comfortable to share any experiences you've had with it?
Sure. So the one, I've only had COVID once so far, and I can't remember where exactly it fell, but it was somewhere after maybe the second or third vaccination.
Okay.
And I don't know where exactly it was within that space. However, I'm also asthmatic, and I did have some pretty intense lung involvement. Like to the point of being a little bit fearful one night of needing, maybe to go to the hospital. But within a day or so of using Paxlovid, it seemed to be starting to control what was going on with my lungs, the extreme asthmatic situation. I think it was like a day or two. I don't know if that sort of fits in with how it works, if that is like roughly what you'd expect. But it certainly, I do feel, kept me from having a serious breathing issue, or at least it reduced it, quite a bit. And I didn't notice any other side effects or anything from it, other than it helped.
Okay, thanks, Nadine. We have a question about Paxlovid. Can you take it if you get COVID more than once? Who would like to take that one on? So, for example, if I had COVID now and I was prescribed Paxlovid, and then in 6 more months I have it, would I potentially be prescribed Paxlovid again? Maybe Inés, is that for you?
Yeah, I am not 100% sure, but I don't think that there's any contraindication to get it twice.
Okay. And I do know, this is only anecdotally, but I do know people who have had it prescribed more than once. So again, I think the good advice here is have a plan, because you don't want to be scrambling if that's something that you want to look into when for when you do have COVID. And I just recently called my pharmacist and asked about if they dispense it or not, so I could have a plan. And again, be sure that you talk to your healthcare provider about what the options might be for you with respect to Paxlovid. And I know in different provinces, it's a bit different in terms of how you access it. In Ontario, pharmacists can prescribe it. And I know there are some medications that are that will impact it. And so it's important for you to have a consult with them, and probably your specialist as well about that. Okay, we're going to move on. I mean, one thing that we've had some people ask about is, are we as people with inflammatory arthritis at increased risk for long COVID, or what does the data say about that in us? And maybe I'll ask both Inés and Dawn what they would like to provide in terms of thoughts there.
So I can just comment briefly on long COVID. We do have a clinic of long COVID at the Jewish General Hospital. Dr. Hudson runs that clinic. And there are some results from studies that have been done and also abroad on this topic. I don't think that we have data until now that supports the idea that patients with any particular underlying condition is at a higher risk of developing long COVID. And I don't think that we do have at this point any way to prevent that. That's my take on that particular question.
Okay, thanks, Inés. Dawn, anything you'd like to add there?
Yeah, so the risk factors that increase the likelihood of long COVID is severity of disease. So the sicker you are, the more like you are. And actually being female in between the ages of 40 and 60. So because many people living with rheumatological conditions are women in that age group, that's what that additional risk would be, not so much because of the disease, but because of female sex and because of that particular age group. So those are the major risk factors. I think we'll learn more for sure. Long COVID's a heterogeneous disease. We don't fully understand why it happens. We don't understand why some people get better and some people don't get better. So I would say that's the best evidence we have today. And so there was a question about the age range. So 40 to 60 in female increases the risk. But I want to emphasize that all those things that increase risk doesn't mean there's no risk for men who are 20 or men who are 80. Right. You know what I mean? Yeah. So, we're looking at very subtle differences in risk. It doesn't mean that people who are outside of that demographic can't get long COVID. And again, with the severity, although that increases risk, I don't want to minimize the fact that there are people who've had mild infections and still gone on to have issues.
Right. So we're kind of talking about, there's not a ton of data out there yet. This is also new, right? Which makes it weirdly fascinating, but also, I'll just be honest, kind of scary at the same time, right? But I'm also a scientist by training, and so it's fascinating to watch like the evidence change over time and see how we do a good job or not of actually listening to that evidence and implementing it into policy, right? So I think we've heard this throughout the webinar. There's, some kind of goalposts for things, but then that's not to say there aren't people outside that are kind of outliers, or like it could happen to you even if you don't kind of fall into the main demographic of what we're seeing. Okay, we've got some questions about the XBB variant as well. And one of the questions we have, I'll give this to you, Dawn, is what can you tell us about the XBB vaccines? Can you explain how those were developed for the newer variant?
Yes. And now I know you are avid readers of the National Advisory Council on Immunization, but here's a really subtle change in how we're talking about this recent vaccine. We're not using the word booster anymore. No more boosters. So boosters sort of imply a little top up, a little something extra, you know, a little plus. We're not using that terminology anymore. This vaccine is specific to the variant family that's in the circulation right now. And the official recommendation is that all Canadians over 6 months should receive this vaccine. But the people who it's super, super important to get it are obviously the people who are the most vulnerable. So we've moved into the phase of this pandemic where it's like the influenza virus. You wouldn't get a vaccine for influenza for a strain that circulated 6 years ago. You want to have the one that's matched to that. And so the belief is that we will have continual updates to deal with whatever the circulating family of viruses is at that time. And the ones that are sort of approved now are the Moderna. I believe we're still waiting on Novavax and Pfizer to be approved, but they'll all be specific to that circulating variant, that family. It's a family. There's multiple variants in circulation right now, but that's what we're moving.
Okay. The other question probably for you too, Dawn, is are the rapid antigen tests still working for these latest variants that are circulating? I've heard some people say, you know, like, I'm not sure if it is. And maybe any tips to help people who are doing those tests make sure that they're doing them properly?
So the rapid antigen tests detect a protein of the virus that doesn't mutate very much. So it does seem to work for these current variants as well as the last few variants. And there are a couple challenges with rapid tests. The first of which is, especially for people who've been vaccinated or recently infected, a lot of the symptoms you feel when you start to feel poorly are not the virus, it's your immune system. So the congestion, you know, the sore throat, some of that achy, sick feeling. And in that first day or two, especially if you've been recently vaccinated or infected, you might not actually have very much virus present. So one of my concerns is always people test and they say, oh, it wasn't COVID, and they move on with life. But it's not a bad idea to test and then to test 1, 2, or 3 days later, because by that point, the virus amount might have increased, and then you might suddenly start testing positive. So there's a disconnect between how bad you feel and how much virus there is. That means that sometimes we don't detect that. The second challenge with the rapid tests is they're not as sensitive as a PCR test. You have to get a really good sample. And, you know, all of us have been swabbing through this pandemic, and some of us are really good at getting back in there and really twisting. And others of us feel that that is very, very uncomfortable and resist doing that. I know that a lot of people now have started with the Omicron variants. A lot of them like to live in the throat. So one of the things that people try to do is swab their throat, which is gag inducing. And some tests, some PCR tests that were developed at McMaster actually involve swabbing your gum line first, because the virus tends to be, because you're coughing up all your saliva, it sort of accumulates there, and then sticking it up your nose and doing the really deep swab, not the other way around. Important. Mouth, then nose, not nose. So getting the really good sample is also a problem. But to be honest, even in people who are really good at taking the samples and definitely have COVID, sometimes if they just don't carry a lot of virus up here, or they have a lot of mucus up here, it still comes back negative. So it's frustrating that we don't have PCR testing, which is a lot more sensitive.
And the other question too is there are some folks who submitted this who have Sjogren's disease. And so they have really dry nasal passages and sinuses. Are there any tips for them in terms of when they do their rapid antigen testing?
Oh, I don't know if Inés has more.
Inés, do you have people in this category who ask you about this?
I really have not had that question before. I think it's super, super relevant. I would just suggest that one thing that can be done is use your eye drops, that there is a connection between that and the nasal cavity that can help with the humidification of the nose, and then at that point do the swab. but really, I understand absolutely where the question comes from, and I don't have a good answer for that.
Okay, fair enough. Another person has asked, will I have to keep getting COVID vaccines? I'm on my 7th vaccine now. What does the future hold? And I know I keep reading the promise of like mucosal vaccines or, you know, nose-based vaccines, etc. Dawn, can you look in your crystal ball and tell us what's on the horizon there?
One of the reasons inhaled vaccines show a lot of promise is because they make the immune response right where you need it most. So the lung is kind of what we call compartmentalized, meaning there's a little bit of talk between your blood and your lung, but the lung really is its own special place. And McMaster, I don't want to brag, but is leading the Canadian nasal vaccine initiative. And one of the beauties of the vaccine that they're designing is that it sort of almost looks like an asthma puffer. So you take a big breath and it gets to the deep parts of the lungs. So in the deep parts of the lungs, you have a lot of immune cells that are really good at, when they're exposed to something, hanging out there and blasting back into action as soon as they see it again. And they also make this antibody called IgA antibodies, which coat all your mouth, all the wet spots of your body. And they're really good at binding to the virus and stopping it from infecting. My hope is that the inhaled vaccines are what's going to stop us from needing so many vaccines, because they have the right response at the right time. And like I said, they come back into play really, really quickly once you're exposed to something. What we're learning is that this virus is mutating to live within people who've been vaccinated. So the whole world, the whole Western world at least, has been vaccinated, and most of the rest of the world has been infected. So this virus's survival, that sort of Darwinian instinct to live, depends on being able to infect people who already have some protection.
Yeah.
And there's lots of mutations to sort of sneak around.
It's a Trojan horse.
Exactly.
Yeah.
And the other nice thing about the inhaled vaccines is they also target parts of the virus that are evolutionarily conserved, that it can't mutate so well. So the hope is, again, that will help us with lots and lots of variants. And whereas the spike protein, which our mRNA vaccines are made of, mutates so quickly that we're seeing lower and lower protection. But that's honestly years away from common use. And we haven't seen, you guys are politically active and advocate, so please write to your local politicians. We have not seen that kind of investment.
I was going to say, we need the money for the research, right?
And we need like the Operation Warp Speed or whatever the Americans called theirs to invest in this kind of technology. Right. And it will also upset me if the Americans get there first, because a lot of the technology for inhaled vaccines was developed here in Canada, and it's a shame that we're not pushing them to market. So that's my only hope for moving past needing to get vaccinated multiple times a year.
Okay, thanks very much. We've got a few more minutes, and one thing that we've talked about as a panel and preparing for this is vaccines are kind of one part of our toolkit to keep us safe as people, living in a time where COVID is pretty rampant. So Nadine, I'm going to ask you, what other things do you do to protect yourself when you're out and about, besides keeping your vaccines up to date?
Okay, I still mask most of the time when I'm in a public setting. I do find it sometimes difficult to do that, say, if I'm somewhere where there's a lot of people and there's a lot of background noise and you're trying to have a conversation and people can't really understand you extremely well through the, the N95 mask. So, I do sometimes have to take off the mask just to sort of be part of a conversation, but it's definitely not my favorite way to go. I do try to keep it on most of the time. Now, if I'm, in my house and people come over, and I think about my kids who are in their 20s and they're out socializing a lot, I don't always like to have the mask on, but I do try to keep my distance if I feel they've been out to some big event just recently and they could be harboring COVID. I'll keep my distance away from them, no hugs, air hugs, that sort of thing. And I'm still definitely sanitizing my hands. Like as soon as I come out of a store where I've touched a whole bunch of things on the shelves and whatever, I sanitize my hands. But I don't know that that's the, the main defense, honestly. I do think that the mask is what is helping the most. And as a person with asthma on top of having other immune type illnesses, I think that keeping whatever I can out of my lungs is probably the way to go more than anything.
Thanks, Nadine. Inés, I'll go to you and then I'll go to Don B last. Any other tips for people? Oh, I think you're on mute, Inés.
Sorry,
That's
there's
okay.
two things that I can think. One is encourage your family members and your close contacts to be vaccinated. This is something which is called cocooning effect, and that definitely is it has been shown to help people that are at a higher risk. The other thing is to make sure that we not only think about COVID, but we also think about other vaccinations that need to be up to date, including influenza and influenza vaccination. As healthcare workers, also we provide care to people with immunosuppressed conditions. We are vaccinated, and we also wear masks at the hospital. That was something that was at some point was not needed, and then during the last 2 months came back. So I think that one thing that is convenient is that we follow the guidelines that come from public health, because there's a reason why they suggest that. And I think that is helpful for everybody that has that lives with an immunocompromised state.
Thanks, Inés. What about you, Don?
I'm a committed indoor masker. That's my major kind of mechanism of protection. And so far, I feel like that's been keeping me safe, but I will say it's incredibly hard. It's incredibly hard to forego all the social events and family events. And one thing we do too is if we're seeing one of our family members who is immunocompromised or is challenged, definitely try to have a cooling off period between events. So, if there's some, a high risk event, I don't know, coming back on an airplane, or, if the kids have been at some event where their masking might have been a little maybe not so adherent, then trying to, because the Omicron has a relatively short incubation period of 2 to 3 days, if you can sort of time those things to make sure that you're not passing it on to our most vulnerable family members. But other than that, that I don't feel we have a lot of good options other than masking, unfortunately.
Yeah, I'm with you. I'm also a committed indoor masker, even sometimes outside in crowded spaces. Like, I'm okay, I'm a nerd. I'm fine with that. And it's just been interesting because I've been reading a lot, mostly from the engineering side of things in terms of clean air, right? And how that's kind of like the next clean water is having clean air, right? So I know at home, in terms of just our furnace, we put in HEPA or MERV 13 filters. We also have just portable HEPA filters that we bring with us places. Like if I have to stay in a hotel, I'm the nerd who calls to make sure that the windows actually open so I can get some fresh air in, and we'll put our air purifier in for a few hours before we take our masks off there. So I know it might sound like a lot, but I just feel quite strongly that I have to protect myself, right? So we have to take steps, and it's individual for everyone, but really part of the webinar is helping people to have good information and evidence-based information to make their own informed choices about things. So I know we've got a couple of other questions in the chat. What I'm going to suggest is that we actually, we're a few minutes past time, and I really want to respect that we've asked our panelists to be here for an hour with us. And I know some people have to get going. So what I'm going to suggest is that we take the 2 questions we haven't been able to answer, and we will get answers back to you on those, but we'll wrap up this part of the webinar. So I'd really like to thank Nadine, Dawn and Inés for joining us today, for answering lots of questions, and for just having like a really fun but nerded out discussion. So thanks for that. For those of you who joined us too, just really like to thank you for your time and questions. We'll make sure that we can answer all of those questions for you. And then we're going to be moving into the drier part of CAPA's AGM next. So people can drop off if they feel like it. And I know some of us will stay on to do some formal stuff that we have to do once a year. So thanks very much to all of you for joining, and really enjoyed speaking with all of you and having all of you join us today. Thanks.